Good afternoon, everybody. I thought we'd get this afternoon's session started after lunch. This is the Fundamentals of Deceased Donation segment. My name is George Isaac. I'm an intensivist from Vancouver, helping to moderate this session, along with colleague and friend Jean-François Lisée from Montreal, also an intensivist working there. Our first speaker, Dr. Stephen Bede, is an intensivist in Halifax, working at the QE2 Health Sciences Centre. He's the medical director of the, or site chief of the VG site there, and has been very involved in the realm of organ and tissue donation, both at a local and at a national level. He currently chairs the Deceased Donation Advisory Committee through Canadian Blood Services, and we're very glad to have him here today to talk about deceased donation performance data. Steve.
Thank you very much, George. I'm not sure if people are going to wander in. That's not a problem. Thank you for the invitation. I get a couple of minutes here to remind this audience that things in Canada have been happening and that a lot of work has been done. And so what I'd like to do to begin this is just to acknowledge in particular a few people who've been significant contributors through CBS, and that would be obviously Sam Shemy, who many in this audience would know, and Kim Young. And in terms of the presentation of this, Karen Hornby's assistance in pulling the data together is certainly appreciated. But what I want to take a moment or two to do is acknowledge the work of all of the ODOs across this country and the transplant programs. I think that what we're going to be able to see is that things in Canada are finally, after quite a few years of relatively flat performance, we're starting to see some change. And that's a tribute to a lot of work that's been done by a lot of people across this country in the various ODOs and the transplant community as well. So in terms of the data that is being presented, it is a compilation of information procured from the ODOs, summarized in the recent system progress report that was published and circulated in September of this year, which many of you would have seen. So the take-home message, I hope, is that we finally have, after quite a few years of a lot of work, I think we should frame this very much as a glass half full situation. There is good news to report. There's a lot more work to be done, and we certainly can't say that we're performing at the level that we as a wealthy First Nation country might want to. Certainly when we compare our performance to other countries, we have some work to do, but as you'll see, we're starting to move the bar a little bit, and that's good news. So in terms of donation performance, if you look at this country, what we're now looking at is system performance, and a lot of people have complained about donor per million as perhaps a faulty metric, but one way or the other, it's a metric that is commonly utilized to look at donation performance across the world, with the highest performing nations being in the high 30 to 40 donor per million rate. Well, Canada had historically, for the better part of a decade, been in the 13, 14 donor per million rate, but now you've started to see real change. And in the last few years, about a 42% increase in the number of donors, about a 30% increase in the donor per million population. Most of that, as you'll see, is related to progress with DCD donation, but there has been some modest increase in neurological donors, and that's particularly telling given that we know the diagnosis of neurological death is becoming less common because of pre-hospital care, ICU care, neurosurgical intervention, culture in the ICU, whatever. So we've been able to see some real progress, and that's translating into more access for some of our patients. If you break it down by province, you'll see a cluster of low population provinces at the bottom of the graph, and it's hard to see any significant change. But in the larger provinces, what you're seeing is a nice but gradual upward slope. In particular, most recently, Ontario and BC have had some real progress. And if you look at the diagnosis of neurological death and organ donation through that route, in general, relatively flat, but perhaps a small positive slope on that across the board. But here's where we see real progress. This is the numbers that look at donation through DCD, and you can see that some provinces, and Ontario is the most impressive. There's been real progress in developing DCD as an option for donation across this country, with Ontario leading the way, but just about every other province has an established DCD program or is about to start offering that. There's some challenges in my part of the country. We have one transplant team to cover 4 provinces, and there are challenges related to that. There's interest in New Brunswick and Newfoundland, but there's some challenges related to that. But in the rest of the country, DCD is either being done or getting established. And when you look at the progress in donation numbers, this has been the largest single explanation for that. So when you divide this metric or present this metric in that sort of donor per million mark, you can see that we're now a little bit over 18, and hopefully the number will be pushed closer to 20. If you look at this by province, what you'll see is that in the original call to action from CBS roughly 10 years ago, a target of 22 donors per million was what was established as a reasonable target. In general, we haven't met that as a country, but perhaps we're on our road. What you do see in most provinces, though, is a general upward trend, and with a couple of exceptions. But we've got widely varying donation rates depending on the country. Has that translated into more access to transplantation? Well, the total number of transplants that have been done has increased, as you can see, by over 20%. So there are more transplants being done now, and that's significant, and most of that is related to increase in deceased donation as opposed to increase in living transplants. If you're on the wait list, we still aren't meeting your needs. The wait times are still longer than most people would consider acceptable, but by increasing donation, we are providing more transplant access to the patients that need it. If you look at this metric here, the people on the wait list, the number is relatively flat. I think that's largely related to people who no longer qualify and are taken off the wait list. But we're roughly 4,600 people who are still awaiting a transplant. So for all our success, there's still a lot of work to be done. And we have the better part of 5,000 people who are awaiting a transplant, and a couple of hundred people per year are going to die in Canada while they await transplant. And there's going to be another number who become too ill to qualify and are taken off the list. So our success is laudable, but we still have work to do. You can see that the numbers across the country are quite variable. In general, we're still faced with a challenge in meeting the needs of the patients in those regions. The wait times for various organs do differ depending on where you live. So if you look at why are we starting to see this bump, a 30-40% increase in donation is a good step towards the target that we have. And why has it worked? There's no question that the development of DCD across most of the province most of the country has been a key contributor, and that work needs to continue. We know from successful models around the world that the leadership of critical care is crucial. It's very hard to get real momentum in supporting donation without buy-in from the critical care community, which makes getting the chance to speak to this community all the more important. So critical care leadership is crucially important, and as part of that, the development of the donation physician role, who are almost always critical care docs, although some emerge docs have fulfilled that role, is key. The development over the last decade or so of a number of leading practice documents and the implementation of those things has increased system performance. And one of the tools in many jurisdictions is mandatory referral, which has increased donation performance. We don't have it yet in Canada, but if you look at, for example, the success in the UK, one of the drivers of their performance has been consistent, timely, and transparent access to data. I think that that's one of the things that we'll try to focus on in the next little while in Canada. Damon Scales has done some work developing a deceased donation data set, and maybe that's one of the things you'll hear about in the next little while. But the transparent reporting of system performance has driven the UK, and I think it can contribute to success in Canada. If you look at the things I just highlighted and try and correlate it with where in Canada do we see these things in place, and does it correlate with higher donation rates? In general, there is a correlation. It's not universal, but if you look across the board there, the programs in the country that in general have adopted the things I've just highlighted have higher donation rates, and the areas that are challenging still have some work to do. Are there other things that may very well contribute to system performance? Obviously. That's, again, things that will be looked at in more detail in the next little while. Strategies around increasing public awareness, the routine application of death audits, I think dovetail into my conversation around transparent and timely data. Professional education is a target for the critical care community that CBS are working on. How much does the funding level for ODOs correlate with performance? Don't know the answer to that, but it seems intuitive that when a system is better funded, it probably results in better performance. ICU and OR capacity are factors in some parts of the country more than others. And as I alluded, the availability of surgical recovery teams may impede progress in some areas. So in highlighting things that are key to success, I think we also have to acknowledge that there's other potential contributors that we have to take a closer look at, and that work will be occurring in the next few years for sure. I'll leave it at that. Thank you.
We have time for a few questions before moving on. I have a comment, Dr. Bees. Do you think that 22 donors per million population is a realistic objective, and can we achieve it? And my second question is, can we go over that with what we have in place in Canada?
I'm very optimistic that 22 would be a modest and very attainable target in the next little while. I know in Nova Scotia we're on track to be over that this year. I was just speaking to somebody from Trillium, and they're doing very well this year. Quebec has done well. BC most recently has started to do really well. So it might be that when we look at the numbers at the end of 2016, maybe we're close to that target already, but if we're not there now, I'm very confident that we'll get there. The next challenge is not 22, good for us, let's stop. It's 30, and then it's 35, and whatever. It'll be progressively harder to attain that higher number, but I think our system is capable of achieving that.
Just maybe a comment along those lines. Dr. B, do you think we should be tagged to a number, whether it be 20, 30, 40, or are there other metrics that could help guide us in that regard?
I don't think the number is as important to the people in the front line as it is to the political mentors or the politicians that want to write a paper about this, because some have legitimately criticized donors per million as perhaps the wrong metric. But if it's a target that one way or the other is something that's looked at around the world, we might as well pick one that's reasonable. But I really think that the real metric is going to be related to other parts of the system. For example, if we look at conversion rate, identification, referral, consent rates, if we're doing things to improve the components of the donation process, then the number will follow. So if we focus on the components of the system, in the donation process and make sure we're doing that better, then that's where the effort will lie and the number will follow almost predictably.
It's an honor to introduce Dr. Wijdicks, which is a professor of neurology at the College of Medicine Mayo Clinic. Dr. Wijdicks is chair of Division of Critical Care Neurology and attending the Neuroscience Intensive Care Unit at St. Mary's Hospital, Mayo Clinic, Rochester. He's the founding editor of the journal Neurocritical Care, the official journal of the Neurocritical Care Society. He has single-authored 12 books on neurocritical care and edited and co-authored 7 additional books, all currently in print. He has over 750 research paper topics review and editorial to his credit. Well, when he was introduced earlier, Sam Shimi said that he felt like a dwarf beside Dr. Wijdicks. Well, I suppose that I feel like a hobbit.
There's more to publications. All right, let's shift focus a little bit and talk. Dr. Shemi asked me to give a talk on pitfalls, and that is important, of course. In fact, it's really the most important thing that pertains to brain death determination. So, the American Academy of Guidelines has identified that there are several prerequisites before you're even going to start thinking about brain death determination. And they're listed here. Coma should be irreversible and cause known. Neuroimaging should explain coma. You don't want a normal CT scan to start off with. Depressant drug should be absent, no residual paralysis effect, no abnormal acid base or electrolyte or endocrine abnormality, and normal temperature, systolic blood pressure should be normal, all very understandable, and everybody would argue, why do we even have to think about that? Of course we won't do that if we don't, if anything of that is present. I'm afraid that there is a little more than meets the eye here. So if we could just simplify it in what it could be, it's just simply examining the patient, look at motor response, brainstem reflexes, do an apnea test, and then document the time of death. So we look at brainstem reflexes, as you can see here. I won't go into specific detail. Basically, look at the reflexes that measure mesencephalon, pons, and medulla, followed by motor responses that should be a no response. Now, when we get to spinal cord reflexes, none of the spinal cord reflexes, as we could see, would have these coordinated reflexes that are described as abnormal flexion or extensor responses, or as decerebrate or decorticate responses. These are very coordinated responses that we typically don't see. What we see in spinal cord reflexes will be more form-fruste, and I'll show you a couple examples. And then move towards an apnea test, which is basically an oxygen sufflation to the patient, disconnect from the ventilator, and then let the CO2 rise to a certain target. And we've noted that the target is approximately 60 torr, 60 millimeters of mercury, where you would have maximal stimulation of a diseased brainstem. That's at least the thought. It takes about 8 minutes to get there if you start with a normal ABG, as you can see here. And of course, the pH starts to decline, and when the pH starts to decline, the patient becomes acidotic, the CSF becomes acidotic, and the CSF acidosis plus the CO2 rise. Both receptors are present in the respiratory centers, which would then stimulate the respiratory centers to drive, to cause the patient to breathe. Again, also precaution with the apnea test. Patients should be normotensive and not have, in the middle of a significant polyuric phase. You pre-oxygenate for 10 minutes, then reduce the ventilation frequency, and then have a blood gas that shows a lot of oxygen molecules that have to turn into CO2 molecules, and the CO2 that should be normal, followed by disconnection of the ventilator. Have a catheter at the carina at 6 liters, and then observe the patient for about 8 minutes, and then if there's no respiratory movement. And the blood gas has shown a rise of 20 torr above baseline, normal baseline, and a PCO2 more than 60 or reach 60, you can declare the patient brain death, and that's the time of death. Your second blood gas is the time of death in that particular patient. And you can see here that it is not causing any problems. You can see the PO2 stays very high still if you do oxygen insufflation and pre-oxygenated patient. These are data from our series of patients. And you can see the PCO2 rises to where it needs to be. So what are the, if that's the basics, what are the pitfalls? And it starts, of course, with drugs. There are many warning signs in brain death, particularly in the emergency department, that could indicate there's a drug present. And this has to do with patients who are in the setting of traumatic head injury or polytrauma or found some of these drugs can cause significant metabolic changes, can cause change in your neurologic examination that could indicate a certain drug that's been present. Some of them are listed here. The bigger question is barbiturates. Can you diagnose a patient who has barbiturates on board? There are still neurosurgeons out there who feel that barbiturates is the treatment for refractory ICP. Unfortunately, that's still the case because it isn't. It doesn't work. It's a complicated drug to use, and it makes the diagnosis of brain death impossible. A very long time of very long half-life that makes it more difficult. Now, the other question is, how about alcohol? What level of alcohol? And I think it should be below the limit of driving. If you can drive at that level, you can certainly be dead with it. Then therapeutic hypothermia. Of course, therapeutic hypothermia has increased significantly over time, and that created a significant abnormality because all these drugs that are administered to a therapeutic hypothermia or targeted temperature management are not getting out of your system as quick as you want. Look at these numbers here. This is percent per degree Celsius decrease of your elimination of drugs that are used. So it is very difficult to know exactly and precisely calibrate how much is still in that patient but once you're using it. And what is far more important is that the odds are against you. This is a paper just got published, a systematic review on the rate of brain death and organ donation in patients resuscitated from cardiac arrest. And of course, they excluded a lot of patients, a lot of studies, I should say, in which brain death was not mentioned or was excluded. But in the studies that they could look at, they found it was about 5% in conventional CPR, 9% in ECMO CPR. So you have a situation here in which it is highly unlikely the patient will be brain dead and is on confounders. And we know pathologically that anoxic ischemic injury damages the cortical mantle and spares the brainstem. So your odds are against it. It's very, very difficult to be reliable when you make a determination in that particular setting. How about spinal cord reflexes? So this is Rembrandt, a Dutch painter, showing Lazarus. The Lazarus sign has been published by my mentor, Alan Roper, in which he could find that the arms would go up and then the other patient almost make a prayer-like movement there that, of course, if you would scare the family if that would occur. It's not very common to see that. It's extremely uncommon if that occurs. Possibly it occurs in situations in which there's marked hypoxemia during this apnea test, in which this can occur. I will show you here the spinal reflex that is much that can occur here. You can see neck flexion, and there's not much happening here in a patient who's brain dead, but then with forceful neck flexion, you can see there's significant movement of the legs that can occur, but you have to have a forceful neck flexion to have it occur. So spontaneous spinal cord reflexes are not that common. It's often provoked, and what you can see. Here you can see that. I'll just show you at the. And here you can see another reflex, the triple flexion response, that is just as common. I would estimate it is approximately 10 to 20% of patients who will have this triple flexion response if it plays. There you go. So here you can see the triple flexion response with flexion in the foot and in the knee and also eventually in the hip. That is only provoked by a nail bed and rarely spontaneous or with flipping the toe. This is what you see all the time. typically will disappear. This particular patient was present for many, many hours after the determinant of brain death. This is important to mention, to document that, so as we alluded to early in our discussion, that this is important that everybody knows and that nobody gets scared about it when it occurs. Let's see how to advance. Oops, sorry. So, are there pitfalls with the apnea test? This is an example that, to me, did prove that we need to have a CO2 measure to know if the patient is breathing or not. This particular patient, it took 12 minutes to get to the PCO2, after 12 minutes started to breathe. And that's, you would not expect that to occur, but you could see that there's a very slow rise in CO2 in this particular patient. There are patients in which the rise of CO2 does not go on average 2 to 3 millimeters of mercury per minute, but it is much, much slower. And that's the reason why you will have to do a PCO2, prove that the PCO2 has risen to the level. We and others have found that patients can breathe if you do an apnea test, but not that many. I've now collected about 6 or 7 of those cases in which I was absolutely certain that all brainstem reflexes were gone. I did an apnea test and the patient started to breathe. And you can see when it starts to breathe around the 60 level, but also many of them much lower at a CO2 that is around 20 to 40 millimeters of mercury. There are some outliers here, and the one outlier here is in here, which is in a child that caused a significant problem when it got published. It suggested that in children the targets would be too high. It's a case that has never been confirmed. And as you can see, all other cases that have been published show that when you're below all the patients that start to breathe are below the CO2 of 60 torg level and target, making it a most likely reliable target. The apnea test is typically without any difficulties. As you can see here, in our experience, only 3 apnea tests were aborted. We did not see cardiac arrest, likely because we didn't go to significant acidosis. And so in overall, the results are good, and apnea test is without any difficulties. But it can be aborted in situations when someone is using a T-piece, not providing enough oxygen, when there's a high flow of oxygen that's administered that could cause washout or a Venturi effect that could not result in oxygen diffusing, a high AA gradient, or chest tubes that would make it more difficult to have the patient, to have adequate oxygenation of the patient. So here you have a patient whose brain then has this chest X-ray. Do you try it or not is the question. And that remains a complicated question. We've found that if we recruit the lungs with simple gradual recruiting of PEEP, with every 3 minutes increasing the PEEP for a minute, and then put a patient on a CPAP valve and provide oxygen flow, we were able to finally do an apnea test. So there are some additional tricks that you can do to do the apnea test to come to a conclusion. Pneumothorax has been described. This is a paper that's recently published with giving oxygen sufflation to patients. High oxygen flow was mostly the cause of these situations, or catheters pushed too far into the bronchial tree, or insertion of a catheter. I've seen people take a nasal catheter, oxygen catheter, cut it in two and put it into the patient, causing problems. And these high flows can cause really dangerous wiggle in a catheter that has no side ports. And here you could see, if this is just to show what the flow to an oxygen catheter can do. Here you can see the catheter at 5 liters. It is a tissue to show how strong the flow is at 5 liters. And then at 10 liters or at 15 liters, it becomes extremely high flow, which you can imagine can cause a pneumothorax in the patient. When that occurs, it often is associated with immediate cardiac arrest, and there's very little to do if that occurs. Here you could see what happens if you put 15 liters through that catheter, and and whipping occurs, which eventually can cause significant injury to the patient. So I declared the patient brain dead, and then I got home and I got a midnight phone call. I have some interesting news for you. The patient is triggering the ventilator. And of course, it's not this. It is called ventilator self-cycling. And that's something that we've now recognized with newer ventilators, that these patients, that it seems that the patient is breathing again, and the ventilator is triggering for some reason. It just typically changes in flow or changes in pressure, small change in pressure. It's commonly in patients who have chest tubes or in very skinny patients in which the heart rate or the heart pulse causes the ventilator to trigger is a common cause, and it's an issue. So simply disconnection is the best way to do, or to change the flow sensitivity into a pressure sensitivity that can resolve that problem. The opposite is also true, that you're going to declare a patient brain death, but you think the patient is still breathing, and you postpone the brain death determination, and therefore may potentially lose an organ donor. There have been papers describing that specific phenomenon in which there's too much reliance on what the ventilator tells you, and not repeating the apnea test. So are there mistakes? The Los Angeles Times likes you to believe that there are mistakes, that a patient was declared brain dead, and then eventually was not brain dead, and that's because someone decided to re-examine the patient. There's a famous case in the US of Zach Dunlap, who was in the ICU, and the trauma surgeon ordered a nuclear scan. Was told there was no flow in the nuclear scan. The organ donation agency was called, where nobody has really an idea of how the brainstem examination was done. The organ donation came in and found that the patient was moving, in fact was localizing, and was trying to get the tube out. And that's what he was telling a couple of months later on the Today Show, showing that that by simple misinterpretation of a ancillary test, mistakes can be made. In my opinion, and the cases that I've been involved with, by looking at what has happened here, it is typically a perfect storm. It's an inexperienced physician who's never done it, or has done it once a year, or maybe once in every 5 years, who misjudges confounders, doesn't look at it very carefully, does an incomplete evaluation, and then it misinterprets a confirmatory test. In those situations, it can occur. Often these patients have, of course, have been found when they were re-examined that they were not brain dead. So do not proceed if there could be a lingering effect of a sedative drug. Please don't. And do not proceed in the emergency department. You don't know anything about that particular patient who came in. You really don't know anything about that patient. Do not use ancillary tests to solve your uncertainties. It will not. And if you cannot know how to do it and you have to look it up, please ask someone else to determine brain death. It is important to develop experience in doing these tests so that you can avoid pitfalls. Thank you very much.
Thank you very much for an interesting talk. We'll entertain some questions from the audience. We'll start with you, Dr. Baker.
Thank you very much. I'm just wondering, in the next iteration of the guidelines, whether we shouldn't open up the possibility of doing the apnea test different ways, given what we know about preservation of lung function for transplantation. I think many of us have considered and are using an ambu bag or Laerdal bag with the CPAP valve and then running a catheter through it. But you emphasize disconnecting the ventilator, and I'm just wondering about other methods such as introducing CO2, rebreathing, or even breathing at 4 times a minute for long enough to get the CO2 up, and still opening up the lung, providing oxygen, and avoiding some of the pitfalls.
Yeah, there are other techniques. The problem I have with, for example, using CPAP is that you have to get rid of the alarm or being able to get rid of the alarm. And many ventilators do not allow you to get rid of the alarm. So you have to be very careful that what you're seeing is not as a result of an alarm and the ventilator catching up on it. I think the simplest thing is to disconnect and to give an oxygen insufflation. The simplest thing, if that doesn't work, is to use a CPAP bag and a large anesthesia bag with oxygenation. The others have tried to raise the CO2 to a certain level and then do an apnea test and see that there's no breathing at a certain CO2. I think many British institutions do that. I have no problems with that as long as you observe the patient while the CO2 is rising. But to do CO2 insufflation might be more complicated because you don't know where the CO2 goes. And I would think that a rapid rise in CO2 could lead to significant acidosis and cardiac arrest. So I'm not entirely sure if that's a good alternative. In my own experience with using disconnection and the way we do it, I found it, it's very, I showed you 3% here, but I think we're now I cannot recall a situation in which it was very difficult to do an apnea test.
Thanks very much for both your talks today, the earlier one as well as this one. Just wondering if you could comment about your practices at your institution. If you have a fairly straightforward cardiac arrest, patient has an oxic injury, no confounders, everything's very typical, you administer hypothermia, how long do you wait once the patient is warmed prior to making the declaration?
Yeah, so it's a commonly asked question. A patient is on therapeutic hyperthermia, has been given sedative drugs, how long do you wait? I don't have an answer to it. I really don't, because what I did fail to mention is that you have a situation, again, in which the chances that a patient is brain dead is low, very low, 95% chance that the patient is not brain dead. Then you have a patient who, if the patient is brain dead, it's understandable that there has been longer resuscitation, a more complicated situation to damage the brainstem in addition to it. And in addition, far often in those patients, there is additional liver and kidney injury. And that additional liver kidney injury make it also more difficult in a patient who has been hyperthermic to clear out those drugs. I think if you have to make a judgment call at some point, you think, well, this drug there's been a little of this drug administered, I think it's unlikely to be a confounder. But there's no precision there. There's not a good way of calibrating it. Unfortunately, we can't. And in certain situations, we cannot do a brain death determination, but should go to a DCD protocol.
Just have a question. You talked a little bit about that perfect storm. And you've described the experiences internationally about who should be performing these studies. Do you have any thoughts or changes in thoughts in terms of your thoughts around the credentials of those individuals involved, given the gravity of the situation, the media attention that this attracts when those very few cases, albeit
no,
done incorrectly?
I don't think I have. I would never go on record by saying that only a neurologist or a neurosurgeon would have to do this, because I don't think so. And I think we have evidence to suggest that any intensivist would be able to do that. We have evidence of our studies in the simulation center that we can train intensivists to do a complete and very accurate brain death determination. I think it all has to do with how often do you do it. And what we've done in our institution is that we decided a long time ago to say we are going to do all the brain death determinations throughout both Mayo hospitals. Our service, our neurointensive care unit, is going to do all the brain death determination so that we can keep doing that and keep our own experience. And that has worked well. Nobody has made any problems with it. Everybody accepted it, and that's what we do. And I think in every institution it would be good to identify persons who would be willing to do that, to reduce the chance that they are making mistakes or they don't have the experience to do it.
Thanks again, Dr. Wijdicks. There was a case report, I believe it was from Atlantic Canada, published in a Canadian journal, that an apparent reversibility of brain death, a patient that did recover function. The question was, and I know you've written a paper on, there's no such thing as reversible brain death. If you could elaborate on that. But let me tell you one of the confounding factors that wasn't appreciated in this case report directly at the time, and that is it was a patient with mastoiditis with intracranial extension of the infection and had an undiagnosed middle ear infection, a middle ear effusion. And would you consider fluid in the middle ear as a confounding situation that makes the cold caloric testing invalid?
No, not necessarily, but I don't think there was more to that case than meets the eye. There was also a significant metabolic acidosis in that particular patient. It was septic when that occurred. And yeah, I think there were so many red flags there that I felt it was brave to get it into publication. And it got somewhere published. And then, of course, someone has to respond to it because the preconditions were not met at all. How much, I think if you look at oculocephalic responses or oculovestibular responses, the biggest problem is that there's a cerumen in there so that the cold water doesn't reach the eardrum. I think that's probably the biggest problem. But I'm not 100% certain if you have no oculocephalic reflexes, if your oculovestibular reflexes are really determining whether the patient has lost these important pontine reflexes. So I think it's not a terribly important point in that situation. And in any other situation that have been published, there have been it's so clear that confounders were not identified or misjudged or poo-pooed away or not looked at carefully. That resulted in reversibility. The reversibility was not someone who got spectacularly better, but in which they were suddenly triggering up the ventilator, or if there was perhaps some movement, some motor movement that is very hard for publications to determine if this is a true motor movement or a spinal cord reflex.
So we'll move on to the next session. So it's pleased to introduce Sonny Denani. Dr. Denani is the chief of the Pediatric Intensive Care Unit at the Children's Hospitals of Eastern Ontario in Ottawa, an associate professor in pediatric at the University of Ottawa. He has trained at the hospitals for sick children in Toronto. He has recently been the chief medical officer donation for Trillium Gift of Life, Ontario's organ procurement organization. He is also leading national research pertaining to practice and standards of determining death after cardiac arrest for the purpose of donation. So, Sonny, I think you have something special for us today.
Thank you. We have a panel discussion, and so we'll invite Stephen Bede, who you already met, and Andrew Healy to the stage. And I'll just wait for my PowerPoint to come up. I am a pediatrician, so I realize 2:30 means nap time. So I appreciate you guys following along with us. Sam's a little older, so he may already have gone to sleep. I'm really honored to be here with this team, who I look up to, and I want to start with the discussion by just grounding ourselves. We do talk about numbers, and we do talk about transplants, and we do talk about organs, but really what we're here to talk about is our patients. And that it's not really about the number of donors or transplants. It's really, for me anyways, about the potential for the missed donor. and it's the grieving families that we're advocating for. And I think for us, that's been a huge culture change, and as we go forward and asking some of the questions and answering them, though it seems clinical, this is what we're thinking about, doing what's best for our patients. Now, we did talk about donation physicians and how that's helped improve our end-of-life care and organ donation in Ontario. And really, this is helped by giving them time and giving them money to help the good people, the coordinators, the ICU teams, do what needs to be done for the families. Now, we went to a number of different countries to get help, and we're very thankful for the guidance Spain gave us, the guidance the UK gave us, and these are countries that do donation, quote unquote, better than us, but do end-of-life care well. And then here in Canada, the support and guidance from Canadian Blood Services and led by Trillium Gift of Life, I think we've created a system where we've got donation docs that help organ donation, that don't replace the people at the bedside, but support them. They're not on call every minute, and they're not involved in transplant, and they don't get paid for a donor. But we are supported to make end-of-life care better. Now, across Canada, there's a number of physicians who support the teams in their hospitals. And then there's these guys here that support them. And so what we want to do is ask these guys some questions as on-call donation support physicians. What would they do in some clinical scenarios? And what I was hoping, because there's a number of algorithms and reasons to call, and we don't have to go through those. But these guys get called all the time to answer some of the questions that you asked Dr. Wijdicks. So what we'd like to do is maybe just get to know these guys a little bit. Now, this is actually JF, and at least he's green. He's a real supporter for organ donation. I get that. Now, maybe in the closet a little bit. JF is from Quebec, and George is from Vancouver, so we've got both sides of the country. This guy took it one step further, not as scary as the other guys, or maybe really, really scary. Andrew Healy is now the Chief Medical Officer for Ontario, and utterly disgusting is Stephen Bede. Did you get it? Utterly disgusting. From Halifax, who has been a pioneer for organ donation. So we're going to start the question with George and JF. We've got a 73-year-old male, brainstem hemorrhage. I think you can see that okay. Appeared declarable by the other physician, no obvious mimickers present or confounding factors. They did an apnea test, which took 20 minutes to get the CO2 to the appropriate level, and there was no spontaneous breaths. But one of them, let's say JF, got a call because of the predominant leg movements on the right. They were reproducible, they were unilateral, and they weren't diminishing. The MD waited 12 hours and then felt more uncomfortable with his own declaration. He had signed the forms and asked JF if we could transfer that child, individual, 73-year-old. So they did repeat the apnea test, and no brainstem reflexes were present yet. And transferred. By the time JF saw this patient, there was some decerebrate movements all of a sudden. Now, this is over 24 hours later, no confounders. An EEG was done, and small voltages were seen on that EEG. Small, but reactive. So, in fact, I'm going to ask the two of these how they did and would manage, but in fact, I'm going to ask you guys as well. So, this is text polling. If you could bring out your phones and text to 37607, my last name, Danani. It's spelt up there because even I get it wrong sometimes. Dhanani. I'll give you a minute. The question is, would you have done the EEG? While you're there, I'm going to take a selfie so that my mom can see this. Okay, anyone voting? Oh, this is excellent. Okay, selfie done. So, most of you would not have done an EEG. Interesting. Oh, I'm having trouble moving on. Moving on. Okay, stop voting. Stop voting. There you go. Would you guys have done an ancillary neuroimaging? So we'll move to the next slide and go ahead and vote. So most people would not have done an EEG. Ooh, quick. Oh, people are not doing an ancillary test. So declared, now moving. Many would not have done an ancillary test. Okay, stop voting. And we'll try to get to the next slide. Janice, stop voting. Nothing. Can I get to the next slide, please? Oh, no, I'm sorry. Well, in the meantime, we're going to ask JF, what happened in this case?
Well, actually, the EEG was done because there was very confusion about the movement of the patient. So the physician who sent the patient at the referring hospital were pretty convinced that it was spinal cord reflex, but we were not convinced at our center that it was. And essentially, the patient, we had the impression the movement from the right leg was actually internal rotation and was sustained with the pain. And so knowing that, we decided to do an EEG, knowing that we would be a little bit the result will stick on us. I mean, if you have no activity, you can say, well, there's no activity, but we know that this finding would have been difficult now to carry on the case. And that's what we done. We wait for 24 hours more, and we did repeat the physical exam. And there was still no change on the physical exam, so we decided to not carry on the case. So we met the family and told them that the patient was not neurologically, by the criteria, brain dead. We did call the Transplant Quebec, the OPO in Quebec, to see if she was suitable for DCD, but she was refused based on age, and she had a history of hypertension. So the kidney were not so good, and we don't take usually livers over 50 years old. So did it end up with no donation?
Now, most of the audience disagreed with either the EEG or the
understand
CTA.
that.
So George, what would you have done in Vancouver?
Have to say I'd probably agree with the audience. When you review these cases, it's always hard whenever somebody else has done the exam and to really know, based on the information you provided, when you say appeared declarable, I think we have heard lots of evidence that we need more than appearances, and it needs to be a strictly followed, essentially checklist to rule out confounders and to document the exam findings, all of which need to be negative to make the clinical declaration. Clearly, when you had evidence of the right leg movement, and in the absence of it being anything more, for my practice, anything more than obvious, say, triple flexion that we're, most commonly seeing, I would be nervous. And certainly the persistence and the fact that subsequently had what looks like decerebrate posturing or movements is very concerning. And so on that basis, I probably would have stopped there in terms of my pursuing of declaration.
So no need to do any further imaging or
a lot of it depends on what's the purpose of the declaration. Is it to help with end-of-life discussion, or is it for the purposes of donation? And certainly there are other opportunities, as you've talked about, in terms of DCD, but you can still have a devastating neurologic injury, not be brain dead, and still talk about goals of care with family. So it really does depend on the purpose of doing the declaration.
Very good. So now, JF, what did you say to the family?
Well, we told the family that the family was aware of the movement and the difficulty from the physician, the referring physician. They were aware that it was a difficult call, and they did understand that the patient was being transferred to a tertiary care center, which some specialists who I was involved, and my colleagues, two of my colleagues were involved, would review all the case and repeat all the exam. So they were not surprised when we told them that the patient was not dead by the neurological criteria. And actually, they were, at the end, they were not, they were kind of happy on the way it took, because they said that we took pretty seriously the declaration of death, and we didn't just push for organ donation. Although organ donation was all in line for, I mean, this patient did sign her card, did told her family that she wanted to be an organ donor, so everybody was for organ donation here, and everybody was working for organ donation. But still, we did explain to the family that we didn't have the criteria, and it was important that she had all the criteria, and she was declared dead before going through this process. So the family actually were happy about the way it was handled in the case of this kind of difficult situation.
Thank you. I think this is a good case example of how the process of organ donation really creates a quality of care piece to withdrawal of life-sustaining practices and good end-of-life care. Good. We'll probably have questions at the end on the 3 or 4 cases. So next to Andrew and Steve, there's a 60-year-old male with catastrophic subarachnoid hemorrhage. Straight from ED, went to the CT scanner and not just had a plain CT, but a CT angio, which revealed no flow. And you got a call to help identify next steps for neurologic determination of death. The question put forth to you, Steve, was that would you accept CTA alone and not recommend clinical exams? So let's put the question to the audience. Would you don't have to repunch in the numbers, you just put in the letters. So there is a small proportion, getting smaller. Looking at, most of you would not. So the next question is, would you ensure CTA, 2 clinical exams, even though CTA showed? So both exams. So maybe I ask the same question in 2 different ways for validity. So Steve, tell me how you manage this situation, and we'll see if Andrew agrees with you.
Well, I'm left wondering if our answers would have been different if we surveyed the audience before Dr. Wijdicks talked this morning. The bottom line is that the diagnosis of neurological death is a clinical diagnosis based on, as you know, a medical condition that can lead to this, no medical confounders, and a clinical examination that's compatible with that. So although in this particular case, an eMERGE doc who had recently attended one of our workshops to talk about this stuff had ordered a scan, at the end of the day, this is a clinical examination. And so what we said was that the pre-existing condition and what we knew about this patient made the diagnosis very likely, but that in order to make that diagnosis, we really had to basically do the right thing, and that is a complete examination of the patient to confirm that they did meet clinical criteria for neurological death, that the CT angio was not the issue in this case. So we went ahead with the clinical exam.
Great. Now, Andrew, if you agree, and then maybe to push you a little bit, do you need 2 exams or just 1 in this scenario?
So I think you need 2 exams if you're moving towards organ donation. I think that sort of promotes the best standard. In Ontario, you need 2 physicians to declare death prior to organ donation, and so for us that question's a little easier. I think there is some literature that sort of suggests the second examination didn't change the results of the first one after about 150 or 200 cases, and so the question is, would we ever move in that direction? I don't think we will. I think the best approach here is the most cautious approach. Yeah.
Good.
Can I have a comment on that?
Yeah, Jeff.
So Andrew, one call that I mean, not once, but a few times I receive calls from this kind of scenario. Mm-hmm. And the physician there is telling me that, I'm alone tonight, and the CT angio is negative, there's no flow, I'm doing the exam, it's negative, I mean, it's brain dead.
Yeah.
I'm not going to perform another exam because I don't have anybody to do it, and the CT angio is pretty much, or he's going to call his colleagues, and his colleagues going to say yes, 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 in the same. What are you dealing with that?
So the situation is there wouldn't be somebody available until the morning? Yeah, so I think the cautious approach there is to support the patient do the second one in the morning. I think how you communicate that to the family, like in all of these cases, is really important. We can be nuanced in our communications to families about what we have found, what the requirements are to make this definitive diagnosis, why we require 2 examinations to be most careful in this circumstance, and still explain the findings that we have now, and move forward with whatever we need to do in order to support the patient to the final diagnosis. This comes up, I think, for all of us on one occasion or another in the circumstance, where you get the CTA in the middle of the night, and there's only one physician with the expertise and knowledge to make this declaration. I think you can absolutely have a clear and transparent discussion with the family, but I think before you move forward, I do think you need the second exam. I don't know how, Steve, how do you feel about that?
Well, I think there's 2 answers. One of them is that yes, you need the second because it's the standard of care that's been defined. 2 examinations. The other practical problem is that in many cases we'll be talking about. I mean, it's the right thing to do no matter what jurisdiction you're in, but in many cases we're talking about programs from across the country, and the paperwork really needs to be right. The standard needs to be not the Nova Scotia standard or whatever, it's the standard. If people are expected to hop on a plane and come, then we need to make sure that we have adhered to the standard at the highest level. And the standard as defined right now says 2 people, 2 exams. So we do that. Now we do it concurrently typically, so 2 people concurrently, but there is the guidelines and then there's the practical. We're talking about expecting teams to fly in from across the country, and it's just the right thing to make sure that the paperwork and the standard is appropriate.
Yeah, I think the story ends there with building trust in the system within the medical profession and for the public to make sure that there's a higher standard, higher quality of care for these patients. I think you're right. Okay, we'll mix it up, JF and Andrew. So 25-year-old with traumatic brain injury after an accident, collision. Confirmed brain dead after 2 clinical exams, but the family's uncomfortable with the diagnosis and declaration. So Andrew, you went ahead and did an ancillary test, supposedly, and the family declines organ donation because they were approached. But in fact, the family also has anxiety around the declaration. And though no organ donation, they are refusing to withdraw the ventilator and inotropic support. So, question to the audience. Now, this family, this individual, before you answer it, is a known a pre-existing wish to be a donor. So, would you overrule the family's donation refusal? And move forward with donation. Interesting. So there's a significant amount of people that might consider this. The second question is, you as the MRP, would you remove the support? So the endotracheal tube, the ventilator, the inotropes, even when this family doesn't believe in brain death? Forget about the organ donation question, declared by 2 physicians. Great, so a 70-30 split that you'd go ahead and do that. There's still a significant group that would continue ventilation. Interesting. So Andrew, I'll have you start. How would you have managed this situation, and what's your experience?
So I guess this comes up for people once in a while at different places around the country. The first question is, would I have approached a family in this circumstance where they didn't accept the diagnosis of death by neurological criteria? And I think unless they've accepted that withdrawal is going to happen, I probably would not have approached the family for donation. So that'd be where I'd start. I don't think families can decide when someone is dead, but they can decide whether they accept that diagnosis. And without accepting that, it's pretty tough to then go on and have a conversation about donation. The second question about whether or not I would override family refusal in the setting where somebody has a registered consent decision is a bit more tricky. I think that in the current system that we have right now, that isn't possible. There may be a legal framework to make that possible. It practically is not possible. And I think, as to your comment earlier, we're building trust in a system, and you really just need one case where that trust is violated to affect the whole system. And to really change how we approach this. So that doesn't mean you shouldn't advocate for this person's wish, you shouldn't communicate with the family effectively, you shouldn't be careful about how you word how the family should make that decision, and that you shouldn't give them time to absorb the consequences of that. But I think if their ultimate answer is absolutely not, I wouldn't proceed with the override.
Very thoughtful. What about you, JF?
I would agree with Andrew. Even if in Quebec we would theoretically, with the Code Civil du Québec, be able to overrule the family and go ahead, it's really, I think nobody would do it.
Sorry to clarify, in Quebec.
So in Quebec, it's written that the last wishes of a dead one is the most important thing, and we should carry on these wishes as much as we can.
Okay.
So knowing that he did sign his donor card or register to any kind of registry, we could probably carry on against the family, but I don't know anybody would do that actually.
Okay.
And it's just it's the same thing as Andrew mentioned, is a trust for the system. Our media in Quebec, and I think in the rest of Canada too, are very keen of those kind of situation. And I'm pretty sure I would be on the news the day after. So sometimes losing a donor is probably better than winning more donor after that. Okay. So I would probably not overrule the family refusal, although we would still work on this family a lot. I mean, putting some liaison nurse at the bedside and try to discuss with the family the benefit of organ donation. But still, we will accept the family decision. And the other thing in Quebec is that we need to have the consent from the family. We need a consent to proceed for organ donation. So obviously, they won't sign it. So we will not be able to do.
I'll let Dr. Wijdicks. They may not have been ready for it. Not on? May not. Oh. Yeah, it's on.
So about overriding, in the state of Minnesota, and I know other states in the U.S., it's legally possible to override if the family member has a donor checked on his driving license. So the organ procurement agencies can override that, and it has happened. But in the overwhelming situation, when the family sees that their loved one has clearly checked it on a driving license, they would feel that this was the best wishes of their loved one. So I don't know how it is legally here in Canada. Also with withdrawal of support, the problem is really once you're taking care of a dead person, you can play hardball or softball. Softball is, and I think that it is extraordinarily important to maintain trust, is to maintain and then continue to have a conversation, and hopefully that conversation would change the family to come to grips with it. Hardball would be to go to a judge, and a judge would then, virtually every situation, decide that the patient is dead and that there's no need to continue care but not in every situation. And we have examples. Once you go that route, it's going to be unexpected. It is not a guarantee that the judge would say that, as you know from several examples recently in the U.S.
Yeah. And Megan Taves will present later on, either this afternoon or tomorrow, on family override, so keep in tune. Now, Steve, you had a comment on this?
I thankfully have never actually been in a situation, but I nobody wants to be the poster boy for this agenda, and yet I wonder why. Because what we know is that families or people want the system to respect their wishes at their end of life, and if it is really crystal clear that they wanted to be a donor, then you know, do you take the stand? And I appreciate that you undermine potentially the trust in the system, but by not respecting the wishes of somebody who said they wanted to be a donor, we're potentially undermining the trust in the system. So is this a difficult journey that could be handled with really good communication skills? Now, I have not been in a position to have to be the poster boy for this, but I wonder, not that I'm looking forward to it, but I'm wondering if that presented itself, somebody has to. And I really do think that when we have an individual who we know wanted to be a donor, we're almost not asking for consent from the family. I mean, we sort of are, but it's more like we know what your loved one wanted. So can we talk to you about how we can make that happen? Do you have any? It's a different type of conversation, and the consent rates are way, I mean, 90 or something, even higher than that, when we know that they wanted to be a donor. I wonder if we were prepared to take a compassionate, empathetic, and timely stand on this difficult issue, whether we couldn't negotiate our way through it. And failing to do so on some level may undermine the trust that people have that when they die, their wishes will be respected. We'll see how it plays out. Sooner or later, somebody's going to be facing this.
Excellent. Thank you for bringing up the counterpoint. I think George had one more comment.
Just the only comment I would make here is that I'd be very careful to separate the issues around their neurological determination of death from organ donation. And from what I'm reading here, and I agree with all the points that have been said, I very much want to ensure that we have consensus on the death point. I'm not sure that we have that from the vignette that's been presented, and so that the discussions around donation further muddy the waters around the trust around the acceptance that this patient has died.
Just to add to Dr. Mead's comment, there are places in the States that have first-person consent. And so the person actually, before their death, signs the consent for donation. It's registered with the state, and then the tissue bank, the organ program, can call up that consent. So for us to move forward on what Dr. B was talking about, I think we as Canadians need to look at that process of first-person consent. And then the family is not approached for consent. The approach is very different. We have consent from your loved one for a donation, but we need to ask you medical questions, and then you get into the DRE. But the consent is done, signed by that person, registered, and they download it.
Very helpful
Something to look at in the future.
Very helpful.
Well, I agree with you, Steve, what you just told. It takes a lot of courage to do that, although, and we did change the way we approach family, although in this kind of situation. We actually don't ask for organ donation. We do say to the family that your loved ones mentioned that he wants to give his organs, so how we should proceed like this, and exactly as you said. But the fact is, are we ready if we go in this kind of situation that we overrule family? Do we have the capacity of discussion and going in all this political storm that we're going to have? And I'm not sure, actually in Quebec, I'm not sure we have this capacity at the moment. So we're wondering if it would be more damageable for the organ donation.
So there'll be some regional differences.
I don't want to belabor this, but the amount of discussion this gets is tremendous.
Yes.
Stephen, you've never been in that situation. Have you been in that situation, Jean-François?
Yeah.
So you've been in a situation where families refused. Once, twice, 10, 100 times?
No, it doesn't happen at our time.
How about you, George?
Yeah, I've been involved, not in the setting of donation, but in end of life.
No, in the setting of donation.
No, not in the setting of donation.
I mean, provincially, once or twice. Yeah.
Okay, so I've been doing this for 30 years. I've never been involved in that situation. We're making a mountain out of a molehill. This is not a problem. And we're not going to compromise the integrity and the trust in the system to fight a family on one donation.
Also, helpful comments, Joe. Thank you, and your experience is valuable. There will be more discussion about consent again in Megan's talk, so lots of opportunity, and this is exactly what we wanted. These are real topics when these guys are on call, so it's very helpful to talk. We have one more, and we have just a few minutes, so I'll give you this one for George and Steve. A 2-year-old non-accidental traumatic brain injury, very emotionally charged, not declarable by brain death criteria, suitable for DCD, very motivated family, consents to donation, and withdrawal first and then donation. After consent, the arterial line falls out. So the question is, would you insist for the declaration of death that the arterial line be replaced, specifically for donation to proceed? And the second question will be, if the family agrees to donation but doesn't want the, I guess, traumatic insertion of the arterial line, which I have seen, would you prevent DCD from going forward or make something else happen? So, to the audience, would you insist that the arterial line be placed for DCD to occur? It's not unanimous, not unanimous. So, you'd continue with DCD even if there was no arterial line. Excellent, excellent. Split. So George, do you want to comment on how you might manage? You can change the age of the patient if that makes you uncomfortable. But
it does make me uncomfortable,
how would you manage,
but it probably doesn't change anything.
What do you see as the potential conflicts?
So for me, I guess the conflict really, ideally, it's quite nice to have an arterial line to be able to really do DCD much more smoothly. I can't say that I've ever done it without invasive monitoring. I think the risks of placing one are incredibly low, can appreciate the stress of the family, and certainly would want consent before going ahead with that. If they clearly were reluctant for whatever reason and didn't want to and knew the imposition it would place to not, I think you could very much go forward without an invasive line. And really, our Canadian guidelines stipulate that you need to be able to measure a pressure, and we have elevated that standard such that we do it with, most recommended with invasive monitoring, but certainly there are other ways of doing so, whether you have beyond just palpation, you can use Doppler. Certainly we've heard about the use of echocardiography. There are a number of other opportunities to ensure that you don't have essentially a pulse pressure and that you're in a non-perfused state to make the declaration of death at that time. It's a little more cumbersome, challenging. It might mean you being at the bedside a little bit more during that end of life and competing with the family's space, and that would be the real push as to why I'd argue for an arterial line, but not absolutely necessary. And I guess the only point would be is I know that we're working on national pediatric DCD guidelines that are very much in the works, but are not yet widely disseminated at this point.
Excellent. So you change your management strategy for that declaration a little bit to ensure declaration was true. Steve, what about you? Agree with the audience? Agree with George?
I don't ever want to have to take care of a 2-year-old. That's the first thing. But let's make him a 32-year-old. The bottom line is this is an opportunity that the family are motivated for, and if we need to modify what we have to do at the bedside to enable that gift to occur and stay credible, then that's absolutely worth it. And whether that's Doppler or echo to confirm that there's no mechanical function from the heart, that's not that big a deal for what's at stake. So I would totally support being slightly creative and still respecting the family.
Anything to add, Andrew or JF? Great. Well, we ran out of time because you guys were chatty, but we have probably 10 minutes, I think, for questions. Is it true? I think there was 10 minutes at the end, 5-10 minutes. So I think there were a number of different topics. Some of them were emotionally charged. I think it's important that if you have questions for each other or for the panel, it's a good time to step up. We get our mics on, please, Mark. Thanks.
I was just wondering the panel's opinion. If it was something more traumatic, like an accidental extubation, would you reintubate the donor for the purposes of donation?
Excellent, excellent. Andrew, why don't you take a stab at this one?
So we're talking about this particular case that's in front of us, like the 2-year-old has lost his art-line and been accidentally extubated. Okay.
Excellent. These are real calls.
Yeah.
These are real calls.
I think this is a motivated family by the sounds of things, and so I think they want donation to happen. And in order for donation to happen, the patient needs to be continuously supported. So I think in that circumstance, I would support with reintubation. I think. I mean, if there was time, you could have that conversation, but likely not much time. So I don't know if other people have different answers.
Matthew.
Thanks, Sonny. And as the working group lead of the death determination subgroup of the PDCD guidelines, Sonny knows exactly what we said on this. And just to one of the points that hadn't been mentioned was that we're really making a distinction here with ante-mortem interventions that do require full consent, as opposed to post-mortem interventions in the NDD cases we were talking about. And so certainly the family consent it would be necessary. But yeah, we in our recommendations we did say that that alternative methods such as echo or Doppler, as long as there was user expertise and so probably calling in the pediatric cardiologist to make sure the aortic valve wasn't opening. For example, if you've never used Doppler in a low flow state like this, probably not the best time to practice. So yeah, just wanted to make that.
Excellent comments. Next question.
Hi there. I'd be interested in the panel's opinion on looking at a system where to be eligible to be a recipient of an organ, you have to be an automatic donor. So this would simplify a process, that would avoid a lot of discussion and perhaps increase our organ donor rates as well.
George, you want to take a stab at that?
I think those are big societal questions, and I'm not sure that they really necessarily come back to the donation community. I think that would be a very difficult sell, and it would certainly apply to some patient populations that are certainly at risk and in need of transplant. But I'm not sure that in and of itself, beyond being another opportunity to educate the greater public, would be a high yield opportunity beyond the educational effect.
Good answer. Thank you. Dr. Baker.
Just wondering about the panel's opinion about organ donation after MAID and whether you use the same criteria you do for regular DCD.
JF, you want to take this?
Repeat the question. Medically assisted death.
Medical assistant. So MAID is medical assistance in dying or death?
So what we did, we were, a bit of history, we're stuck in Quebec with a conscious patient who asked a DCD. He had a high C-spine injury, and he was able to make his own decision and his own acceptance of care. And he did ask for organ donation and stopping the breathing machine. So that make us that caught us right away, and we're not able to answer this question very well. We had a lot of discussion between our surgeon and our team to answer this kind of request. So we went over it for medical assisted death. So we had two ethic committee in Quebec that did position themselves on pro that we should offer DCD for patients who go through medical assisted death. We didn't have any case so far. In my hospital, since we started the program of assisted medical death in Quebec was started in December actually last year, so it's been mostly a year now. I've been involved in my hospital to reviewing all the cases, and in about 16 cases that we had for the last December, there's no case that were suitable for organ donation. Okay. So far we didn't have any cases in Quebec that went through organ donation, or even that family asked for DCD that I'm aware of. They didn't came to Transplant Quebec, although. But we are ready to. We're in the process of creating the way we're gonna do, and if patients go through the process of assisted medical death, ask for practically it's a DCD, we will carry on the case, and we have surgeon ready for it, and all our major hospital have agreed on carry on those kind of case if they come. So yes, we are going to do it if we ask it to do it.
And I know other provincial and national organizations, CBS, Trillium, et cetera, are working on similar strategies. So I think that's a consistent viewpoint.
One thing that's important is at the moment the rules in Quebec, it's mostly cancer people can access to this program, but we know that the government wants to make it wider and may accept more people in this program. So we may have some more candidate for organ donation later on, but at the moment it's very few of those that can, because they mostly have cancer.
Thank you. One last question, I think.
Yeah,
Randy,
thanks,
sorry.
So it seemed fairly clear that there was a lot of support for continuing the process of having a second physician do the brain death examination and declaration. One idea that's been floated around a little bit is the idea of actually virtually bringing in that second physician in to do a telemedicine-based second examination and determination. Just wanted to throw that out there and see what your reaction is like. I mean, we're using that more and more often to actually manage patients while they're alive and providing critical care. Is there a role for this, or at least exploring this to see whether or not a virtual presence of an expert to be able to provide that second examination could be as good as having somebody there in person?
Stephen, why don't you take the field? What do you think?
It's an interesting proposition. I guess in theory, I actually think that it may have some real credence if we had the right monitoring tools, so that if you were to have somebody who was physically present and actually knew how to do a physical exam appropriately, and the second person was in a position to visually confirm that it was done correctly and the result that you expected was visible, then I actually think that might be an opportunity, especially if the extra virtual person you're getting truly is an expert. Never done it and never anticipated it, but it might be an intriguing thing to consider.
I'm going to ask my moderators, we still have a few minutes, right? Dr.
I always wondered what I should do during my retirement, but now I know.
Just outstanding.
We would be happy to have you at the bedside anytime.
Put that to a vote. I think one last
That's
comment.
a way better way to end it than my question, so I apologize. But
Yes.
I just wanted to make sure there is clarification that the law in all provinces does not say you need 2 examinations, but you do need 2 physicians. And just to be clear, right, and those 2 physicians can observe and do the same examination at the same time. I think that question about video conferencing is a great idea to test in terms of validity and reliability. That's a great suggestion. And congratulations to Sunny and the panel. I thought it was a great discussion. Thanks very much.
Great way to end, actually, with congratulating the panel and the guys who asked questions. I think that was a fantastic group discussion, and hopefully it was worthwhile. Thank you very much, guys.